welcome to today's webinar. As Laura mentioned, it's Analyzing Global COVID-19 Statistics and National Policies. This webinar is a brainchild of a partnership between the Australian Human Rights Institute and their director, Professor Louise Chappell, and the George Institute, and it was made possible through a UNSW COVID-19 Rapid Research Grant. Our project in that grant was understanding the sex and gender dimension on women's health and well-being in COVID-19. Today, we're lucky enough to have 3 speakers from different parts of the world, and I thank them for agreeing to participate despite the early morning times. Our first speaker is Dr. Sana Peters. She's a senior lecturer at the George Institute for Global Health at Imperial College London, UK, and an associate professor at the University Medical Center Utrecht in the Netherlands. She has a conjoint appointment as associate professor at UNSW, and she was awarded a postdoc fellowship and completed her postdoc training at the Cardiovascular Epidemiology Unit at University of Cambridge. She leads a program of research on women's health and sex differences in diabetes and cardiovascular disease, working on big data, often through routine care or administrative records, but also from large bespoke cohort studies and meta-analyses of such studies. Our next speaker is Dr. Athena Pantasis. She is a data management and analysis consultant from the Global Health 50/50 COVID-19 Sex-Disaggregated Data Tracker. She has expertise in demography, population health, and quantitative methods. She obtained her PhD in sociology at the University of Washington and has worked for the US Census Bureau, UNAIDS, World Bank, and other institutions supporting data collection and conducting statistical analyses for research and evaluation of global health interventions. And our last speaker, but definitely not the least, who will be joining us by video because I believe it's around 4 a.m. in the US, is Dr. Rosemary Morgan. She is an assistant scientist at Johns Hopkins Bloomberg School of Public Health. She has expertise in gender analyses, and intersectionality. She currently leads a sex and gender analyses core for the NIH-funded Sex and Age Differences in Immunity to Influenza Center. She is co-primary investigator on a project exploring the gendered effects of COVID-19 in Bangladesh, Kenya, Nigeria, DRC, and Brazil, and this is supported by the Bill and Melinda Gates Foundation. She also coordinates an international gender and COVID-19 working group. So those are our 3 excellent speakers. And Sana will be the first to go today. And our questions for her, and she'll be speaking more about this, is what is meant by a gender disaggregated analysis? What can be discovered by analyzing global COVID-19 statistics, national policies and activities, and what can be learned about sex differences in heart disease? Sana, over to you.
Thank you, Cheryl and Laura, for those introductions. I'm really happy to be able to speak today. Next slide, please. So I'll be indeed talking about sex differences in COVID-19, but before I do so, I would start with just some introductory words about the need for sex-disaggregated data analysis, and not only analysis, but a sex-disaggregated approach. Because historically, most medical research was conducted on predominantly male populations, and it was assumed that the results from those studies were equally applicable to women. But as time has moved on and as people have started to look at sex differences in various medical areas, we now know that that's not necessarily the case always. Next slide, please. And here's a couple of examples of why that's not the case and why we can actually learn more if we split our data by sex. So for example, between 1997 and 2000, 10 drugs were withdrawn from the US market because they had serious side effects. And 8 of those drugs posed more serious side effects in women as compared with men. Research has also learned us that the warning signs of heart disease in women are often missed because women are diagnosed as if they are a man, and their symptoms are often different from the way heart disease presents in women. And also, access and quality of care is not the same between the sexes. So just assuming that women and men are the same doesn't work and may cause harm for women, but also for men in some cases. Next slide, please. So we can increase our knowledge about disease health outcomes, not only for women, but also for men, by undertaking sex-disaggregated analysis, but also by including enough women in studies, because we also still see that women are underrepresented in many disease areas, and and without having sufficient women in studies, we can't conduct those sex-specific analysis. Next slide, please. So then on to the sex and gender dimensions of COVID-19. I think there are broadly 3 dimensions. First of all, there are the patients, the people affected by COVID-19, but there are also sex and gender dimensions when it comes to the effects on vulnerable women, and also when it comes to the effects on healthcare workers. And I will start with the patients. Next slide, please. So this is data quite early in the pandemic, actually, already from Global Health 50/50, and the next speaker will talk more to that. But what I want to show on this slide, what this slide shows, is that on the x-axis, you see the different countries. On the y-axis, you see the male to female ratio in deaths among confirmed cases. And what you see is that in virtually all countries, there's more men dying of COVID-19 as compared with women. So these are deaths among confirmed cases. So there's this quite substantial and consistent sex disparity, in the sense that men are more likely to die once they have confirmed COVID-19 as compared with women. Next slide, please. And we don't quite know why that's the case, but there are a couple of hypotheses. The first one is that sex hormones may contribute to different immunological responses in women as compared with men. And it's known that women in general have a stronger immune system, which is also illustrated by the fact that women are in general more susceptible to, are more likely to get autoimmune diseases like rheumatoid arthritis and multiple sclerosis. So, and that is negative. But in the context of COVID-19, a strong immune response may result in the lower death rates among women as compared with men. So in addition to that, there's also sex differences in health behaviors. So women in general have fewer comorbidities than men, and are also less likely to smoke and to consume alcohol, especially in low and middle income countries. And we know that the healthier you are, the better your prognosis is once you get affected by COVID-19. And then, and this is a bit more hypothetical, but there may also be sex differences in adherence to social distancing and outbreak management regulations. So women may be more likely to wash their hands regularly, or to keep the 1.5 or 2 meter distance as compared with men, and that may also result in lower death rates. Next slide, please. So then the other 2 categories, so vulnerable women and healthcare workers. Given that we're now in this pandemic situation, given that there have been quarantine measures implemented in various places, it may lead to a rise in gender-based violence. And actually, there's already emerging evidence to show that this has been the case. This rise can be explained by first of all, by the increased incidence of violence. So given that women are closer to their perhaps violent partners or other people who may harm them, it may increase, but there's also a reduction in protective and preventive efforts due to the focus on COVID-19 healthcare services. And when it comes to healthcare workers, well, women face higher risks of exposure to COVID-19 than men when it comes to their occupational roles, because women make up over 70% of the workers in healthcare and in the social sector. And they're also more likely than men to conduct informal or unpaid care as compared with men. And early in the pandemic, there was already a lot of media attention for the fact that the protective equipment used by nurses and doctors doesn't really suit the female body. And there was like this quote in the, I think it's from The Guardian, where they said that it's essentially made for a huge rugby player and not for women. So that may again pose women at an additional risk once they are caring for their patients. Next slide, please. So what do we need in terms of data? And again, the next speaker will talk to this, but I just wanted to provide a few suggestions. But first of all, countries should collect the data and report the data, because without the data, we just can't assess the situation. We don't know what the situation is like when it comes to sex differences in COVID-19. And secondly, we must also ensure that that the data are being used to close the existing gender data gaps. And again, most countries and other organizations do not do that as yet. And in terms of the future, countries also need to invest. The bureaus of national statistics, for example, should get additional funding or additional resources to be able to collect the data that is needed to respond to the current pandemic, but also to be prepared for future pandemics and future events that will benefit from sex-specific data. And in addition to having the data, countries must also commit to using the data to develop and implement evidence-based policies. Because at present, most policies, both medical policies, but also all the isolation measures, for example, and other recommendations, they are sex blind. They don't take this gender component into account. And that's, I think, also much needed in the future. Next slide, please. I'd now like to move on to a couple of slides about why sex differences are important. I said a few words about it already, but just to illustrate it a bit further. Well, cardiovascular disease and diabetes, as Cheryl already mentioned, is my main area of research, and it's also the area where we know most, I think, about sex differences. Historically, there was this widespread perception that cardiovascular disease was a disease that mainly affects men, and while men are indeed more likely to get CVD at a younger age, the lifetime risk of cardiovascular disease is approximately similar between the sexes. And also, given that women live longer than men, there's actually more women than men dying from cardiovascular disease each year. And what you can see on this slide is that the first presentation of cardiovascular disease differs between the sexes. So in the blue line, you see, for example, coronary heart disease, which is essentially heart attacks. And men are substantially more likely to have a heart attack as the first cardiovascular event as compared with women. But women are much more likely to get a stroke, which generally happens about 5 to 10 years later in their life as compared with men. So there are really substantial differences between the sexes there. Next slide, please. There's also differences in the effects of risk factors. So we know that the main risk factors for heart disease and stroke, in addition to age and sex, are blood pressure, smoking, and diabetes, and high cholesterol. And what we've seen in large-scale studies is that whilst these risk factors pose an excess risk of both stroke and heart disease in both sexes, the magnitude of that effect is often stronger in women as compared with men, especially when it comes to diabetes. What you see on the top half of that slide is that diabetes poses an approximately 154% excess risk of type 1 diabetes, I should say, of heart disease in women as compared with men. And type 2 diabetes poses an approximately 44% excess risk of heart disease in women as compared with men. So again, risk factors just act differently between the sexes when it comes to heart disease and stroke. Next slide, please. However, despite these risk factor differences, the overall risk of heart disease across the lifetime is higher in women as compared to with men. However, the presence of diabetes may result in a smaller difference between the sexes. So on the right hand side, you see the overall difference, and you see that women are having about a third the risk of heart disease as compared with men. But in the presence of diabetes, it's approximately half that risk. So women catch up in the presence of risk, in the presence of certain risk factors. Next slide, please. Then onto medications. Women remain less likely than men to receive guideline recommended treatment. And this slide shows that over time, women were consistently less likely than men to receive guideline recommended statin therapy after they had a heart attack. So these people are definitely at a high risk of getting a next heart attack. Guidelines all over the world recommended that these people should be getting statins and high intensity statin therapy, but women are just less likely than men to get that. And this is not something that we only see in this study, but this is something that you see consistently. Next slide, please. So just a couple of concluding words. As I've illustrated, there are important differences between women and men in cardiovascular disease. And as we've now also started to learn also in COVID-19, we can use large databases to address these sex differences. But in order to do so, we need to have the data available. And well, why do we do this kind of research? Well, to inform health policy. And poorly conducted or reported research can lead to ineffective and potentially dangerous health policies. As general recommendations, we should ensure that there are sufficient numbers of women in scientific studies, but also when it comes to data collection, that the data are collected on women as well as for men and reported as such. And we need that, and once those data are available, we need to take a sex-specific approach to collecting, analyzing, and reporting those data. Next slide, please. This is just again to repeat my points with regards to COVID-19. So, like I said, we need to collect the data, invest in the collection of sex-specific data in the future, but also commit to using those gender data in health policy. Thank you very much.
Thanks, Sana. That was really great. We've now finally have really good data on cardiovascular sex differences in cardiovascular disease, and hopefully we can replicate the same thing in COVID-19. Our next speaker is Athena Pantasis, and she'll tell us more about the volunteer-led Global Health 50-50 initiative to track the availability of sex-disaggregated COVID-19 data on the number of confirmed cases and deaths, and why we must be cognizant of the need for well-designed sex and gender COVID-19 research that represents all patients. Athena?
Hi, thank you for that introduction. Good afternoon, good evening, good morning. I'm very happy to be here with you today. Next slide, please. We can go on to the next slide. Yeah. So I'm going to start by talking about our data tracker. That is the website for it, and I have peppered my slides with the website. Please visit it. Next slide, please. So this, again, the web address. But so this is a map of the world and the countries we track. The ones that are not yet tracked are in gray. So you see we're covering, well, 99% of the reported cases are tracked in our tracker. 179 countries as of the beginning of October, but the ones in red have not produced data on either cases or deaths in the past month. Next slide, please. So what are we trying to answer with the tracker? Are men or women more likely to contract COVID-19? Once infected, are men more likely to get severely sick and die? Do differences in men and women's risk of dying vary by age? What is driving the difference in illness and death among men and women? And then the role of intersecting characteristics. Next slide, please. And so what are we tracking? The primary variables are cases and deaths by men and women. Additionally, we collect data on testing, hospitalizations, and intensive care or admissions in men or women. And this provides kind of a clinical pathway, if you will, for COVID-19. And then also we are collecting data on cases and deaths by sex and age where it's available, and then cases of male and female healthcare workers. Next slide, please. How do we do it? There are 17 volunteers and a few staff members at Global Health 50/50, as well as partners at the International Center for Research on Women in India and the African Population and Health Research Center based in Kenya, who manually go out and look for this data. We're looking into doing some data scraping where it's possible, but unfortunately while many countries have very nice dashboards that make for easy scraping of the overall numbers, they don't necessarily include their sex-disaggregated data there. And where did the data come from? We're generally trying to get data published by ministries of health or official publications of data. It comes from dashboards, it comes from surveillance reports, which can be daily, weekly, or monthly. Sometimes they're press releases that are only available via Twitter or Facebook or other means of social media. And sometimes we get downloadable files of data of cases and deaths that have sex information. And when there are data gaps, we do outreach and advocacy to try to fill those data gaps. Next slide. So what challenges have we run into? So the publication method, the periodicity, the location changes. There are broken links frequently. The indicators, definitions change. Countries change what they report, basically. Sometimes countries just stop publishing, their data by sex, or they'll update the rest of their data, but will not update the sex disaggregation portions of the reports or dashboards. Sometimes the data won't be published officially, but it'll be part of a presentation given by the government to some people. Sometimes we get a copy of that. Sometimes we don't because it's not saved or archived. Sometimes it's not integrated into regular COVID-19 reporting, but instead is part of additional reports that we have to seek out. And the overarching challenge there, what drives these, is that there's no globally mandated centralized system for collecting sex disaggregated data on COVID-19. Next slide, please. So then why do we need it? And I have put together a few slides to kind of demonstrate why it's interesting. COVID-19, as the previous presenter showed, COVID-19 indicators differ by sex. These are the most recent ratios of male to female cases and male to female deaths from our data sets. And slightly more men than women are being diagnosed, but a good bit more, 1.4 more men to every woman are dying, at least in what's reported. And then you can see from these violin plots, there's substantial variation across countries. So the next slide. So generally, we'd like to show you the pathway with all 5 indicators: testing, diagnoses, hospitalizations, ICU admissions, deaths. But the most commonly reported ones are cases and deaths. Here I show you cases and deaths for Australia and England to show in 2 places that you wouldn't expect to be very different. There's still visible differences in the sex differentials we're seeing. Both in Australia, slightly more women are being diagnosed and are dying of COVID-19 as of early October, late September. However, in England, you see a fair bit more women being diagnosed. However, a fair bit more men die of COVID-19, again, as of late September. The next slide, please. But also, these differences vary through time. And this is Australia. And so from April through early August, Australia was reporting more men dying than women, though similar numbers of cases by sex. But by September, women were making up more than 50% of diagnoses and deaths. So, next slide, please. So, what we're seeing is that over time and across settings, these sex differentials are different. And so we need sex disaggregated data to inform the responses to COVID-19. Sex disaggregated differences can inform hypotheses for what is driving risks in both individuals and the population. And these risks are maybe changing through time and differing across settings. And this suggests we may need to tailor responses to reduce gender-based inequities in health. And these responses will need to be responsive to changes through time, and these responses will need to differ across settings. So I'd like to thank you for your time. There is the website again, my email, and also general email for Global Health 5050. We would love more volunteers. And also, if you find data that we don't have, please give us let us know, because we would love to include it. Thank you very much.
Thanks, Athena. Yeah, if anybody has any questions, we'll read them out later on. But I certainly do have a couple of questions regarding Global Health 5050. But before we do that, our final presenter today joins us by video, and Dr. Rosemary Morgan will discuss on what we have learned about how women are most affected from pandemics, what happened in past outbreaks, and how COVID-19 research, response, and recovery efforts can be tailored to support women. Laura, thanks.
Hello, my name is Rosemary Morgan. I'm on faculty at Johns Hopkins Moberg School of Public Health, and I'm here today to talk to you about the impact of COVID-19 on women and the need for gender-responsive pandemic plans. So why is this important? Well, we know from past and current experience that pandemics like COVID-19 are not gender neutral. That women, men, and gender minorities are differentially impacted, and that there are primary and secondary social, economic, security, and health effects related to sex and gender. So primary short-term impacts include things like greater severity of disease and mortality among men, as well as infection risk among women care workers, while secondary long-term impacts are related to social, economic, and security effects, of which women are more impacted. These include greater economic insecurity, domestic violence, and informal care responsibilities, among others, and I'm going to be touching upon some of these today. So despite the fact that pandemics are not gender neutral, our responses to them often are, both in relation to policy, interventions, as well as research. And overall outbreak responses consistently fail to meaningfully include gender analysis. So I'm part of two projects which are looking to understand and mitigate real-time differential gendered effects of the COVID-19 outbreak. These are funded by the Bill and Melinda Gates Foundation, as well as the Canadian Institute for Health Research. And it is a comparative case study in Bangladesh, Nigeria, Kenya, the DRC, Brazil, Canada, the United Kingdom, China, and Hong Kong. Please do visit our website for more information. So what are some of the gendered impacts of COVID-19 specifically on women? Well, you can see here there's quite a long list, and this includes things like increased economic insecurity, increase in teenage pregnancy, lack of access to sexual and reproductive health services, including maternal health, increased rates of domestic violence, increase in informal care responsibilities, lack of women's voice and agency, an increase in stress and mental health issues, and increased cases among healthcare workers. I'm not going to have time to talk about all of these today, but I do want to touch upon a few, particularly in relation to lessons learned from past pandemics. So one thing we've seen in past pandemics, and we are seeing this in relation to COVID, is an increased economic insecurity among women. So overall, the majority of low-wage and part-time workers are often women. Many of them are women of color. And in the United States, where I'm based, for example, many of them are African American. So such workers have greater income insecurity and often face a greater risk if and when their places of work are shut down. So for example, during Ebola in Sierra Leone, quarantine measures closed markets, really destroying the livelihoods of traders, the majority of whom were women. So while men lost their jobs also, we saw men return to work much quicker than women did. So 13 months after the first cases were detected, 63% had returned to work compared to only 17% of women. And we're seeing similar patterns in relation to COVID, but the data is still emerging and we're still right in the middle of the pandemic. And we're likely to see in similar patterns as we continue to move through it and past the pandemic. So the next thing I want to touch upon is in relation to maternal and sexual and reproductive health. So during past pandemics like COVID-19, we saw increased rates of maternal mortality, as well as reduced access to sexual and reproductive health. So health emergencies, often what they do is they distort local health agendas, with most local capacity and resources diverted to service the immediate needs of the pandemic, which can impact routine service provision, including maternal health care and sexual and reproductive health services. So during Ebola in Sierra Leone, for example, the combination of a diversion of resources and also combined with women's fear of going to hospitals resulted in around 3,600 additional maternal, neonatal, and stillbirth deaths. This was in 2014 to 2015, and this number was parallel to all deaths as a result of the virus itself that year. So that means this number was equal to or greater than those who actually died from Ebola. So there's also reduced access to abortion and contraception services as a result of the diversion of resources, and we definitely are seeing similar patterns in relation to COVID-19. We saw during Ebola an increase in teenage pregnancy, and we're seeing the exact same thing in relation to COVID. I mean, take this article that was just published in August, where that shows a dramatic rise in Kenya of early pregnancies amid school closures. Although, the data is still just emerging and we're still learning about this, we are seeing similar patterns now, today. So many of us who study gender and health systems, particularly my colleagues who study health systems in fragile and conflict-affected states, speak about the need to build back better, to build structures and responses that take into account gender and other inequities and respond to them accordingly. Really, how can we expect to have equitable outcomes if the structures and processes in which we work are themselves inequitable? If health systems are inequitable, how can you expect equitable health outcomes? This pandemic has really shown that people are able to find different ways of working and are able to make accommodations to those who need it. So this pandemic and our response to it is really giving us a chance to reimagine the way things are currently done and to build back better. We now have the opportunity to build gender responsive plans at both the global and national level. But what is a gender responsive pandemic plan? Well, it is one that takes into consideration the intersectional needs of women, men, and gender minorities in planning, data collection, response, and recovery. This specifically includes considering and addressing how women, men, and gender minorities experience differential primary short-term as well as secondary long-term social, economic, security, and health impacts. So how can we use a gender responsive pandemic plan to minimize the gender impacts of COVID-19? So this information here is taken from an article that we published in Nature that looks at what some of the things that we need to do before a pandemic even happens, during a pandemic, and after a pandemic. So before a pandemic, we really do need to learn from problems and solutions during previous outbreaks, like Ebola, like Zika, like the first wave of COVID-19. We need to make sure that we have systems in place for collecting disaggregated data. So data that is disaggregated by sex and other stratifiers. This could be race, location, income, education, ability. This is really important. So we know what is going on and how people are being differentially affected. And it's really important that these systems are in place before a pandemic even happens, because we know how important it is to have accurate data. Because if something is not measured and counted, it is often treated as if it doesn't exist. So during a pandemic, and we're right now in this stage, we're right in the middle of COVID-19, we need to accept that outbreaks affect groups differently and that we can't treat everyone the same. We need to make sure that we collect the intersectional gender disaggregated data across different aspects of the national response efforts. And we need to make sure we're funding research about gendered impacts of the virus and fast track the findings from that research into policy and strategy. After a pandemic, we have to make gender central to the lessons learned for recovery and for future pandemic preparedness. We need to appreciate the wider gendered impacts of transition planning. So for example, governments should consider how staged return to work policies make women or men more or less vulnerable to a second wave of infection, and how the rapid lifting of lockdown measures might see a surge in demand from women seeking help over domestic abuse. And a third thing is making sure that we're developing and implementing feminist recovery plans. There's a number of very good examples right now coming out of Hawaii as well as Canada that really detail what a feminist recovery plan is and what are some of the interventions that need to be in place. So a gender responsive pandemic plan will help to minimize the gendered impacts on women by considering what needs to happen before, during, and after a pandemic. So such a plan supports women's livelihoods and economic security, including through social protection programs, looks to reduce domestic violence and support survivors, looks to ensure access to sexual reproductive health services, including maternal health, protects women health workers, increases women's voice and agency, reduces the gender gap in informal care roles and responsibilities, implements mental health support programs, and ensures sexual reproductive health education and services for adolescents. So I like to end my talks with an invitation to join the Gender and COVID-19 Working Group. So this is a network of over 500 individuals across academia, civil society, multilateral organizations, and government. Currently it's a Google group, a place to share resources, connect, and collaborate. We also meet once a month. If you're interested in joining the working group, please visit our website and send us a message and we can send you an invitation. Thank you very much.
Thanks, Rosemary, for sending us that video. We now have a question for Sana. How do you think governments will or should use this data? And I think probably Rosemary sort of touched on that a little bit, and their responses to COVID-19. And what is the response from policymakers so far?
Thank you, Cheryl, for that question. And also, I really enjoyed the talk of the other two speakers who I think both touched upon this slightly. I think at present, we see that governments do virtually, well, I wouldn't say nothing, but very little when it comes to gendered responses. There are indeed governments that collect the data that we would like to have, but at present, there's very limited countries or regions or organizations that actually develop policies to then actually respond then actually provide a gender-specific response to the impact of the pandemic. And I think also here we should consider the direct impacts of COVID-19 that are gendered, as all the speakers showed. So we need to think about whether the treatment that is provided to COVID-19, whether that should be gender-specific or not, or whether the preventive measures, whether we should provide sex-specific recommendations. At present, we just don't know whether that's going to help or whether that's going to be worthwhile. Although there have been some groups that stress the importance of masculine behaviors on COVID-19 responses. So men may be less likely to adhere to the regulations simply because it's not considered to be masculine to wear a face mask or to wash your hands 20 times a day. So those things are at present not really considered by the bodies that make the policies. So I think that's relevant when it comes to the direct response to the effects of COVID-19 on getting infected or not. But as Rosemary, I think, just outlined very elegantly, is that there's more to the pandemic than just the virus. There's also all the indirect impacts that in many cases seem to disadvantage women. So she indeed touched upon women's economic security, but also women as caregivers, not only to people with COVID-19, but also, again, the notion that given that people are forced to work from home, women are still taking up more childcare responsibilities as compared with men, and that, of course, is something they have to. They also still have to work, so it may, in the long term, more negatively disadvantage women that they had to look after the children during the quarantine and stay-at-home orders. So such things are at present just not being considered or not considered enough. But I think, should be. And as more data comes out and as more organizations start to become mindful of these important gender impacts, but also, like Rosemary measured, the other dimensions of intersectionality, so racial differences, ethnic differences, those should really be considered in order to respond to both the current but also the long-term impacts of COVID-19.
Absolutely. Athena, did you have anything to add to that?
One thing I would stress there too is that I think data use is very important. I have seen in a number of venues where people are kind of dismissive of the data that is coming out, not even just necessarily sex-disaggregated data, but they're not using official data for COVID-19. And I think we're really missing an opportunity to kind of push that back to governments, because when you use the official statistics and when you're putting it out there, they're compelled to improve them if they're not accurate, if people are finding them not accurate, if they're not able to be useful. Like, you are compelling. And if I just really stress that we need to use the data we have to kind of move this forward, or else we're never going to have better or more complete data. And then I would also say that some colleagues at Global Health 50/50 have recently been doing a policy review looking at gender-specific, gender-responsive policies and also how that intersects with the data availability to COVID-19. I can't really give you much of an update on it, but I do see that some of my colleagues have joined if they wanted to chime in about that more.
Great. And is that data going to be published when?
Oh, yes. The policy review will be made public. Yes.
Great. And I guess this question is to you both. How do you think this research will drive us towards more effective care? Sana, you have your mute
Sorry,
off.
I can go first because I saw my name on the sheet. Well, I think we see in the taking it step back away from COVID-19 and again looking at heart disease. There's now sex-specific guidelines and women-specific guidelines telling physicians, well, first of all, raising awareness about the presence of sex differences, and also providing suggestions on as to how to deal with with women-specific issues in heart disease. And I think the same we can do similar things for COVID-19 because we now learn increasingly about again the differences in immune response, but perhaps also differences in the effects of risk factors. There's evidence emerging that some risk, well, again, smoking, for example, is more prevalent in men as compared with women, at least in lower middle income countries. So when it comes to preventing worse COVID-19 outcomes, those are things that we could consider, that we know already and should consider, I think, in responses to treatment, or at least in effective care. When it comes to the medications that are currently recommended or in development, I think it's too early to say whether they are equally effective, women as compared with men. But what we should be doing now is collecting those data, because if we don't include enough women or men in the trials, then we end up in a situation where in a year's time we say, well, this drug works, but we don't know whether it works equally in women or between the sexes. So collecting the data, I think, is crucial at this point in time.
I agree. Athena, did you have anything to add to that?
Well, what I would bring up is that there's also an issue of access to care, which then can inform how well we understand care working. And it's a big concern in some of the settings our partners work in particular, where we see huge sex differentials, but what we think is that a lot of women just aren't being counted, either because they don't have access to testing or their deaths are less likely to be recorded for anything, but maybe specifically this. And all of that information would really help in understanding, are women faring better? And if not, why or why not?
I guess that's a difficult thing with data collection. You can only do as much as you can get. We'll start with the questions from the audience now. And while people are thinking of their questions, I thought I'd ask Athena one question. I mean, obviously we need more organizations like Global Health 50/50 to advocate for sex disaggregated data. But my question is, how did that start? How did the need, no, we know that there's a need, but how did the idea start with disaggregating COVID-19 data?
So I only recently joined Global Health 50/50, so I will give a very brief explanation as far as I understand it, because I joined after the tracker was underway. But Global Health 50/50 began a few years ago, and they focus on producing an annual report, as well as a lot of advocacy work and other things, but that one of the facets of this is monitoring the availability of sex disaggregated health data. And that's just one part of a very large portfolio. So, but because they were already doing this work and concerned about this availability of sex disaggregated data in health, as the pandemic began, they started collecting this data and then saw that other people were not collecting this data, and the tracker evolved from there. That's my understanding.
Thank you. We had another question come in from one of the registrants asking about the indigenous population and COVID-19. I've spoken with our Aboriginal and Torres Strait Islander group here at the George Institute, and it does not seem to look like we have publication on indigenous numbers of indigenous people with COVID-19. but there are quite a bit of resources on the impact of COVID-19 on the indigenous population, and I'm happy to share that to those interested. Laura, do we have any other questions?
No, no others have come in so far.
Oh, great. I guess we'll finish up early, but before we go, there's another webinar in this series that's happening on the 24th of November, and it's entitled "What We Know About Family Violence Services and COVID-19." Where can they access the link, Laura? Are we just going to put it up on social media closer to the date, or it's already up?
The link is the same Eventbrite. There's 3 in the series. So the same Eventbrite page on which people registered for this webinar, they can register for the next one.
Okay.
And it will be all across our socials, Twitter, LinkedIn. So plenty of places to find it.
Great. Well, we're finished. 3 minutes back of your time. Thank you again to Laura and Gabrielle, and to Louise, who I think has, who I can see has joined our webinar. And also obviously our speakers, Sana, Athena, and Rosemary. Are we going to make this video available? You said we were going to make it available. Laura, where can they get it?
Yeah, so the link for the recording will be emailed out to everybody who's registered after the event.
Great, including the speakers.
Yeah.
All right, thanks everyone. Have a good evening, good morning, and good afternoon.